Good morning, good afternoon, and good evening to colleagues across the globe as we celebrate together World Cancer Day and the theme of these 3 years of Close the Care Gap. The International Pediatric Oncology Society is proud to present a webinar which is entitled Integrating Adult and Childhood Cancer to Close the Care Gap. And it's my privilege as the SIAP Advocacy Chair to briefly mention our fabulous lineup for today. Laila Hassisen from Rabat in Morocco, who is the immediate part of the president of the French African Pediatric Oncology Group. Vikramjet Kanwar from Varanasi in India, who is the co-chair of the Global Health Partnerships working group. And Richard Sullivan from King's College in London, who's a NCD WHO advisor and a giant in global oncology. We'll be hearing from them shortly, but first a few housekeeping notes. This event's being recorded and will be available following the live session on the SIAP Knowledge Center. You can go ahead with that slide, Anelia. There we go. We encourage you to use the hashtags Close the Care Gap, Childhood Cancer, and @WorldSIAP to take part in the conversation on Twitter. And I think everyone is going to be engaged both today and over the following weeks with both World Child Cancer Day, World Cancer Day and International Childhood Cancer Day events. For this webinar, please use the chat to write your questions and comments, and we'll engage happily in lively conversation on the side. We may be able to answer some of your questions straight off the bat, and we'll reserve the real goodies for the Q&A at the end. So hopefully you'll be represented and heard. So if you'll allow me a few brief opening remarks, and we'll go to the next slide, Anelia. Each year, about 429,000 children and adolescents are expected to develop cancer globally. And the outcomes, as you can see here, vary substantially from the deep red to dark blue, depending on where you live in the world. Next slide, please. So you'll forgive a pediatric oncologist for making an investment case. Certainly, the work that we do, there's extraordinary value for money in potentially. High-income countries have shown that an overall survival of more than 80% is possible for childhood cancer, and the length and quality of that survival adds value. The relatively low cost of treatment is also proven. And we can add value as a community in other ways, supporting, as we've done recently, universal health coverage, raising the quality of subspecialists in general, and collaborating on drug access. And our flagship project, and you can show the next slide, Anelia, is the Global Initiative for Childhood Cancer, which is a WHO-driven project which aims to, in the long term, to achieve exactly that, and certainly in the short term, we can call it that. 2030 is certainly the short term to achieve a 60% survival and to reduce suffering for all children with cancer. But the question today is a slightly different one. So why this webinar? Well, adult and pediatric providers work side by side across the globe. We share labs, operating theaters, radiation machines, etc. And the question we want to pose is, can we work together to close the care gap? How can we foster the equity in care that our patients need and achieve SIAP's goal, which is absolutely translatable to the adult paradigm, the right care at the right time by the right team? And my advocacy team have made a point that I must direct you that if you wish to join us, that there is the details. We'll put that in the chat later, how you can find us. But to today's webinar, so I'm very pleased to introduce once again Laila Hassisen from Rabat in Morocco, who's a stalwart of SIAP and the French African Pediatric Oncology Group, currently their president. And she is going to talk today on the power of partnerships. Thank you, Laila.
Thank you very much, Alan. It's my pleasure to be connected with you today and share insights about this crucial issue of partnership and developing partnership between low and middle income country and high income country. Next slide, please. So why do we give special consideration to childhood cancer? Because even it is rare compared to adult cancer, we know that it is the first cause of non-traumatic death in high-income country, and when WHO will arrange all the problems related to infectious malnutrition in low-middle income country, then cancer is the emerging issue. Childhood cancer is completely different from adult because there is special issues related to development, maturation. Children is not one, it's a different age group, and each age group has its specificities, and histologically it is completely different. We don't find the same tumors that we found in adult. Most cancer are leukemia, lymphoma, embryonal tumor with very different clinical presentation and difficulties for diagnosis. The growth is rapid, but it's also very good response to chemotherapy. But since children will live for many years, the impact of long-term effects is much more important. But even with all this, it is considered as a curable disease, and the 90% survival rate can be achieved in some setting. So how pediatric oncology has been developed, and probably it's similar for adult cancer, it's through partnership. So a partnership is very important, because before being interaction between institutions, it is first of all interaction between human being. Next slide, please. So those who love books about personal development, you will like this book about the power of partnership, and this book emphasizes the difference about a partnership model versus domination model. Next, please. So the partnership model, it's the support mutually and respectful and caring relations. So because there is no need to maintain rigid ranking and control, there is also no built-in need for abuse or violence. Partnership relations free our innate capacity to feel joy, to play. They enable us to grow mentally, emotionally, and spiritually. Next, please. So there are 7 important relationships in all the partnership. There is a relationship with our lives, with our loved one, our co-workers, our community, our nation, our world, our relationship with the nature and the spirit. Next slide, please. So there are pediatric oncology models that have been developed through different partnerships. And the major challenge in pediatric oncology for the next few decades will be how to translate the gain achieved in high-income setting to all children worldwide. And this will be achieved through partnership. So careful designed initiative, development of national and regional framework for collaboration and incorporation for clinical, biomedical, and health services research are crucial to meeting those challenges. Next slide, please. So this pediatric oncology model have been well studied, and there is a lot of lessons that have been studied and published, and you can see this in this paper published by Raul Ribeiro. Next slide, please. So you can see in this model that developing pediatric oncology in low-income setting initiates through international collaboration, international partnership, and international agencies. So you can see in this table that it initiate through the continuum of care by the funding from international agencies, and this needs sustainability from the government, and the partnership is very important in this field. Next, please. But as I said, partnership is first of all interaction between human beings, and you see in this table that this partnership initiates through the interaction between leaders from high-income country and leaders from low-income country. So committed leaders are necessary to define, develop, and implement and maintain the collaboration of the programs. The leaders facilitate interinstitutional and institutional communication and encourage hospitals to mobilize resources. Without leadership, there is no partnership. Next slide, please. So to summarize, partnership is crucial if you want to develop pediatric oncology. What do we need for fruitful partnership? We need leaders and leaders, then leaders from both sides, high income and low income. Those leaders will interact and set up a sustainable collaborative program and engage government. Next slide, please. So leadership is widely recognized to be a critical component of an effective health issue. The impact of good leadership across the health system are wide-ranging and catalytic for improving the performance and retention of health workforce. Next slide, please. So a leader can have a partnership with him or herself, him or her loved one, co-workers, community, nation, world, and spirit. Next slide, please. So the partnership needs to develop leaders first. So leadership is critical component of health system and may be particularly important in sub-Saharan Africa, where clinicians takes a significant management responsibility, and many publications emphasize the need of sustainability of leadership development. Next slide, please. So there are example of partnership to develop leadership, such as the implementation of palliative care nurse leadership fellowship program in Uganda. So this article describes an innovative model of nurses leadership training in Uganda to improve the delivery of supportive care. The belief is that a confident, skilled, resilient, empowered cohort of nurses leaders will not only grow personally, but also will be able to contribute to the national development of pediatric oncology and palliative care in Uganda. Next slide, please. So we need to be put in a virtuous circle where leaders develop partnership and partnership develop leaders. Next slide, please. And with this virtuous circle, you can develop such leaders in Africa, and those leaders can develop sustainable partnership. Next slide. So there is very different perspectives. So Mao Zedong said that don't give me fish, teach me how to fish instead. But Mrs. Obama said, first of all, ask us if we eat fish. So those leaders knows what is suitable for them, for the pediatric oncology and for their community. Next slide, please. So, and they are able to develop sustainable programs such as what have been developed during 20 years by the Francophone African group. Next slide, please. And to achieve survival rates of 60 to 70% in some tumors and move from 0% survival to 60% survival. Next slide. Same example for the Can Care Africa and the achievement for nephroblastoma and supportive care. Next slide, please. Next slide, please. So there is also a South-to-South partnership in Africa between Malawi and South Africa group. Next slide. As I said, partnership can be with nature, and you can see this publication where the use of natural products such as peanut butter improved the survival in childhood cancer. Next slide, please. So we, as African, and from the beginning of the time, there is the divine principle of Ubuntu that have guided us and guided the African society. This is an authentic, individual human being, is a part of a larger and more significant relational, communal, societal, environmental, and spiritual world. We as African, we believe in the Ubuntu principle. We believe in partnership. Thank you very much.
Thank you very much, Lala. Appreciate that. It's and a shout out there for using a South African turn of phrase. So wonderful. Thank you very much, guys. At 117 participants, it's very nice to have all of you here. Please, as Olga's been saying, put any comments. You can put comments or queries or anything in the chat. We'll pick up on any questions at the end when all three speakers have spoken. And so with that, it's my privilege to introduce Vikramjet Kanwar, who's from Varanasi in India, spent a long time in the US and is back home, and is the co-chair of the SARP Global Health Partnerships Working Group. And he's going to talk to us today about targeted intervention in pediatric partnerships as a model for care.
So greetings, everyone. I'm still getting used to the webinar format because this is always a challenge when you can't see your audience. You kind of have to assume that they're lapping up everything you say. However, Lila's made my job easy in the sense she's given a nice broad overview of pediatric partnerships and pediatric oncology partnerships. And moving forward in this section, we will briefly go through some of the basics and some of the principles that may be applied more broadly. Next slide. So if you look at the World Health Organization, you look at the IAEA, you look at other international organizations, one thing most international health organizations are good at is producing quite a wide variety of summary graphs and slides, etc. But they sometimes leave the average oncologist wondering, how can I best contribute, or how can I best get involved in helping my colleagues, helping my patients, helping patients across the globe, given the scale of issues concerned. And I think this is a challenge that affects all parts of oncology, but in pediatric oncology, to some extent, we're a small piece of the puzzle. It makes it a little easier in pediatric oncology, not that much easier, but a little easier. Adult oncology, the numbers scale up dramatically. So we'll look at what pediatric oncologists have been doing and then see what parts are translatable and how. Need a next slide? So if we look at cancer, globally overall, it's the second leading cause of death throughout the world. More than 19 million cancer cases per year, 10 million cancer deaths per year. And pediatric cancer deaths are a fraction of those, but still a significant number of patients. If you look at disability-adjusted life years, which is something public health physicians are fond of using, most of you will be familiar with that, but just to recap again, essentially if you lose 1 year of life to disability or 1 year of life period, that's a disability-adjusted life year. So in childhood cancer, 7.8 million disability adjusted life years are lost per year, almost all of those years of life lost. Very few due to disability, most due to actual death. Breast cancer is 19.8 million, cervical cancer 10.2 million, lung cancer is way up there at 41.4 million. So these numbers are somewhat overwhelming. World Health Organization has therefore chosen from their perspective to focus on what they regard as the low-hanging fruit or the smallest numbers amongst those. So the Global Breast Cancer Initiative, the Global Strategy for Cervical Cancer Elimination, and the Global Initiative for Childhood Cancer have all been formalized in the last few years. And they're all aimed at trying to reduce deaths and disability adjusted life years in those three areas. Next slide. So switching back to what Lala was just talking about. So twinning institutions from high-income countries to low-income countries is an idea that's been around for about 35 years. It started in 1986 with the La Mascota project in Managua, Nicaragua, between Monza and Milan, Italy, and Bellinzona in Switzerland, addressing a single disease state, acute lymphoblastic leukemia. And the results were significant. They were able to show survival where previously no children survived. As a result, Saya Montevideo in 1995 issued a statement adopted in 1997, which encouraged every high-income center to potentially partner with a low-middle-income country center to improve childhood cancer care. And that model continued for the next, I would say, few decades. I was a fellow in 93 to 96 at St. Jude, and Raul Ribeiro, all of his colleagues from Latin America were traveling back and forth and building capacity, imparting knowledge. So this was truly something that was a spark that helped kindle the development that subsequently occurred. And our SAB Global Health Partnership Working Group still looks over some of these projects and assists Marty's efforts. Anelia, next slide. So this is the challenge in any partnership, whether it's pediatric oncologists, whether it's collaborations, whether it's oncologists treating adult patients working together. We have an agreement in principle. The question is, do we all have the same principles? So partnerships become a lot easier when you're working with people you've known for a while, who you're familiar with, often from the same part of the world. And it's obviously exponentially more difficult when you start to reach out and truly go global. Nelia, next slide. So I can be forgiven my one graph. So the variety of interventions in childhood cancer. So if you look at childhood cancer in lower middle income countries and where resources are coming from, the bulk of resources are still coming from the local government, with the state government, with the federal government, the hospital, the infrastructure. But what is really important is to help develop that. And that's where these targeted interventional partnerships come in. You can call them twinning, institutional partnerships. Short-term medical missions and short-term experiences in global health have a place, but as far as developing ongoing care, short-term projects suffer from the difficulty that you cannot always see the consequences of what you do. And as a result, even though they have become increasingly popular, they have drawbacks, as we'll see. Anelia, next slide. So short-term interventions have downsides, and I'm not planning to go through all of them over here. Like those of you who work in low middle income countries are probably familiar with some of these. Like short-term interventions can sometimes be unintentionally disruptive. Like, they may bring in practices or may bring in medications which are not going to continue once that mission has departed and can therefore cause issues and problems for practitioners in the area. Similarly, those who go, global health has become increasingly popular, and rightfully so. Like, medical students, medical trainees want to get exposure, want to get experience as they go around the globe. But the challenge is making sure it takes place thoughtfully. I think a lot of centers like Texas Children's and other centers have now got a good feel for how places outside the United States are impacted. But I think some smaller programs sometimes still struggle with ensuring how medical students, how residents can visit and not leave a footprint that's necessarily deleterious. A simple example is Uganda Cancer Institute had to issue reassurances only a couple of years ago after a relief organization issued an appeal for medications, not realizing their appeal was read by local families online and gave them cause for concern that maybe the institution doesn't actually have medications to treat their children. Nelia, next slide. So, what are the guidelines for successful targeted institutional partnerships? So, Socrates said, like, about 300 BC, know thyself. Be clear about your motivations and be transparent. It's very easy in the field of cancer care or the field of childhood cancer to feel that everything we do is beneficent. Everything we do is for the patient good. But it's always important to take one step back and make sure what we're doing is truly with that in mind. It's essential you have a local physician or nurse champion or champions in order to develop these partnerships. You need leaders, and as Leila put so eloquently, like partnership develops leaders, leadership develops more successful partnership. You need local nurse champions, local physician champions who can move these projects forward. And training not just the physicians, but the nursing staff and support staff is key to any partnerships being successful. Mutual respect is needed, and power asymmetry is inherent with all these partnerships. A written MOU can help clarify goals. It's not a fail-safe. The best MOU is not going to guard you. And nevertheless, it can sometimes help people to be clear as to what they hope to achieve. And remember, while target institutional partnerships are a sustainable relationship, they're also just a stepping stone. So they're not an end in themselves, but they're a means to greater ends. And those greater ends are improving care, demonstrating success, and allowing us to secure local and government funding to improve care yet further in the area we are, and empowering the institution and all those within it to eventually participate in regional networks and institutions with similar problems. Next slide. Provided we follow through with all these guidelines, we don't have to worry about ending up in this kind of scenario, which used to happen rarely, but would occasionally happen in this world. Next slide. So unity is strength, division is weakness. So as we've already discussed, WHO and IEA initiatives can sometimes appear top-down. Partnerships can sometimes leapfrog the twinning or target institutional partnerships phase and move forward directly. So Dr. Pramesh from Tata, a decade ago, pushed forward for a national cancer grid And when it first came out, there was actually some degree of pushback. But gradually people have got used to the idea of a national cancer grid with both adult and institutions treating pediatric patients throughout India. And it's taken several years, but now standardized guidelines are being published, which are specific to the country, with tumor boards and other knowledge sharing opportunities. And this, in many ways, is the long term goal in partnerships, as a second step, you might say, beyond targeted partnerships or twinning. Next slide. Anelia, next slide. Okay, so how can oncologists close the care gap? Sorry, one slide back, my apologies. I think there's a lag. Okay, so Lela described pediatric oncology partnerships in different kinds, and Richard is going to go on to explore how oncologists treating adults view these different options. And we all share a common purpose. So hopefully working together, we can slowly but surely address gaps in care. And as we all know, it's not a panacea. Partnerships are not something to sprinkle on an issue and expect solutions to arise, but they are a powerful tool. And you can use those to help close the care gap in targeted areas around the globe. So each oncologist can look at their setting, see if opportunities for collaboration partnership exist, and most importantly, what their expectations might be. Thank you. Next slide.
Yeah, I think we're going to go back, Anelia. Thank you very much, Vic. We'll keep this for the Q&A for some fun cartoons, only one graph and a lot of food for thought. We appreciate it. So our third speaker, folks, is, some would argue, and I hope you blush with this one, Richard, one of probably the most global of all oncologists, Richard Sullivan, who's always somewhere interesting in the world, but he's here today with us. He works out of King's College in the UK, and he's, amongst many other things, a non-communicable disease advisor to WHO. And he's talking to us today on bridging childhood and adult oncology through research collaborations and global health system strengthening. Thank you, Richard.
Alan, thank you so much. Well, I'm sorry to be very disappointing for today. I'm in exotic, sunny London at Guy's Hospital, so I'm sadly nowhere exciting, but it's absolutely wonderful to be with you all. It's lovely to see so many friends on as participants, and thank you for asking me to give some reflections. Strangely for me, this is going to be a PowerPoint-free discussion. My first reflection, I guess, is to say that divergences between childhood and adult oncology, I think, have always intrinsically been there. My concern really, I guess, is that these have been growing over the last decade, but perhaps actually even within oncology, our respective tribes, surgeons, radiotherapy, medical oncology, as the disease becomes ever more complex, our interventions ever more complex, we're getting less and less able to understand what each of us is doing. And I think maybe the post-pandemic period, this is an ideal opportunity to step back and think about how we can bring ourselves together. If you read most of the last oncology commissions that have been published since when the first one came out in 2011, the Affordable Cancer Care, all the way through to the cancer surgery, the fantastic radiotherapy commissions, right up until the 2020 Sustainable Care for Children with Cancer Commission, what strikes you is two things. Firstly, how much commonality of problems are faced by the adult and childhood communities? And B, the fact is, what surprised me is, how is it that no one's actually talked to each other? Yes, there are sprinkling of adult oncologists with childhood and vice versa, but really the two communities have been completely separated in time and space. If you go back and look at the 2020 commission from the Childhood Cancer Commission, if you look at panel 3, talking about the limitations of studies in the childhood cancer world around collecting global incidence, survival and mortality data, the list reads exactly the same as for the adult commissions. So somehow we've let these silos and we've let age get in the way of common sense. But The caveat to this, of course, is, as many of my community pediatric oncologist people, friends will tell me, is the adult oncology community really dominates the power dynamics for research and care across the world. It's not to say, of course, that childhood cancer has not had huge success. I think you only have to look at the WHO initiative on childhood cancer medicines now to realize that the enormous strides as an individual community that's been made. And let's remember, there are only two other major domains now within the WHO portfolio, one on elimination of cancer of the cervix and the other one on breast cancer. But power is still very firmly in the hands of the adult basic and the biopharmaceutical community. And worse still, in my view, is the dominance of this group really over the narrative and strategic direction, which means that global cancer, and by that I mean cancer control in low and middle income countries, is being sidelined and ignored. A recent Oncology publication came out, showed that less than about 3 to 4% of all research coming out of the UK, USA, and other high income countries is actually co-authored with low and middle income countries. What none of you in the childhood cancer community will be surprised is that 3 or 4% of collaborative research is dominated by childhood cancers. So where are we going? I guess if you look at things now in the post-COVID period, I think we're going to be in a very different world in the next 5 years. There are going to be huge post-pandemic changes afoot. All the data indicates there are going to be substantial economic contractions across the world. There's a rise, of course, of nationalism and even nationalism in the research agendas. They're going to be much more complex therapeutic ecosystems as people move around to find care or because they're forced to because of conflict or climate change. National health systems and national cancer control planning is going to find itself under significant pressure, both financial, social, and political. And that's not even to mention the new actors moving into the space. The Belt and Braces initiative that China's pushing in terms of the global health agenda. And of course, old and new conflicts that are going to radically alter the therapeutic geographies of cancer. But all of this talks to a time now where alliances and cooperation are going to be even more essential to deliver sustainable, affordable, and equitable cancer care to all patients, irrespective of their age. So I think this probably speaks to the need to reframe this dichotomization between childhood and adult cancers. And I would argue actually even between cancer and non-cancer systems. And it begs the question then, what are the commonalities in terms of systems, research, and training? And maybe let me give you a few reflections on that. And I'm glad Vic's already mentioned one of these. Let me start with training and education. I've been incredibly impressed with the work across the globe at the moment, trying to bring together research training to bridge childhood and adult oncology. Vic mentioned the National Cancer Grid of India, and particularly I'd like to point out the Credo model they have, this annual research training workshop that they run every single year. It's a remarkable workshop because it brings both researchers in childhood and adult oncology together for a solid week of protocol development and research methods. It's a model I think that's going to be adapted by aortic and the MENA groups as well. And again, picking up on what Vic said, cooperation really does start with kin. If you train together, you stain together. And depth and time matter, and having people brought together and trained in research methods at a very early stage in their career, and then have that continual follow-up, is an absolutely fantastic way of weaving together research communities from both childhood and adult, in my view. I think with the research itself, there are clearly huge synergies and commonalities, particularly what I'd consider to be the second translational space. And by this, I mean implementation science, health economics, political economy, health research, health services research, affordability, scale up, implementation of interventions. These are all common thematic areas for both adult and childhood cancers. Building infrastructure as well. It is really crazy the way we dichotomize out building research and care infrastructure for both childhood and adult oncology. When you think about the necessity for training across a very, very wide piece of research methods and care. And I think it speaks as well to the need to educate the research funders in this area. I personally don't get a sense that the big research funders, the NCIs, the CRUKs, the DKFZs, the big ones in South Africa, really have wrapped their head around how to provide research funding that integrates capacity building or indeed programs in the second translational space between the adult and childhood community. And I could literally think of one hand how many I've actually seen where there's been an attempt to do that. And it also strikes me that, and this is again what Vic was saying, that there's a need to think much more holistically about building national cancer control plans that have both childhood and adult oncology in the same room at the same time. Again, I've been on too many missions when it's completely dominated by adult oncology, review groups where there is the childhood oncology comes along a bit later. And that's a real mistake. It's a structural and organizational mistake. So really, to wrap up, I want to focus on the last bit, which is this idea of, I've already alluded to, this idea of politics and power. So John Kingdon, one of the doyens of public policy, that said to affect change, you had to align politics, policies, and solutions. The politics of cancer rarely has the voice of childhood cancer in there. Again, if you were to look at the WHO, the big alliances, it is dominated by a certain narrative in a certain group, and it's about changing this. I've got no easy solution on how to do this, but it's about engaging childhood cancer community at really the highest level of the political and policy agenda section. And I like this idea, and to build on what Layla's talk was saying, it's about becoming part of the agenda setting. A lot of policy failure in cancer control isn't conspiracy, it's just frankly ignorance. People don't talk to each other, the communication is not there, the understanding of commonalities is simply not there. For that, campaigning, networking, that's what you need to do to break open what are often very closed loops, and I think that's going to be really essential. The voices of children with cancer community, I feel, are a great deal more authentic when you're talking about global cancer. And I love the word that Layla used, Ubuntu. It's really interesting. I am because we are, and I remember in Zulu, I think it means humanity towards others. It's really important. I think in the childhood cancer community, there's often, I'm going to say this with great trepidation here, but there's often a feeling perhaps of subservience or inferiority to the great, big, massive adult oncology. But if you reverse this and ask the question, who has done most to support cancer control globally in low and middle income countries, it is the childhood cancer community, who's done more than any other group to push the agenda in terms of real solidarity and partnership in cancer care and research that frankly goes wildly beyond what we've ever seen really in adult oncology. So I think there are very good reasons why both adult and childhood cancer communities should and must walk across the bridge. And really now is the time for those solutions. So thank you very much indeed for giving me the time today to give those reflections. And Alan, back to you.
Thanks so much, Richard, really brilliant. And I'm like a student furiously writing down and keeping notes, and there's been some interesting stuff in the chat. I think we're going to go on to gallery view with the slide. Anelia, if you can just give us that last Q&A slide. And I'm gonna put questions to the panelists backwards. You guys can shout in the chat if they. I'm going to reflect some of the things that have come up in the comments, and also some questions myself. So Richard, I mean, it's a compelling. You've made a little summation, and you've given us some really nice, what I don't know if you can call it low-hanging fruit, but places to start to bring our diverse community. Medicine, not just oncology, as you point out, back together. A key question: who is the target audience if we're trying to reboot relationships? Do we start with individual providers? Do we start with key opinion leaders? Do we go after institutions?
Like always, I don't think there's one easy solution for this. I think, first of all, I talked about the narrative, the political narrative at the top, and I do mean the IEAs, the WHOs, the UN, the World Banks. Certainly my feeling is when I sit on some of these committees and I talk to them, they see the childhood community, cancer community very far away. Strangely, it's an interesting thing. It's just, they just do not understand it as being part and parcel. And if they do, it feels like an add-on. And I think there's that advocacy about having senior members of the childhood community at the table all the time. I mean, Vic reflected on his experience with the National Cancer Grid of India, which was a remarkable ability to bring incredibly disparate communities together at a national level. That needs to be done at the supranational level. And I would agree with you as well. And I'm sure, I think Kathy's on all this discussion, that a lot of national countries as well fail in bringing their paediatric and their adult community together. But a lot of this is about political action at the research funder level, at the supranational level, at the national level, just first and foremost.
Great, thank you. Vic, there was a practical, I've got a little spin here about style and substance, but there was a practical question from Diane Berger in the slide you referred to, targeting docs and nurses and support staff, and she wanted to know what you meant by support staff, and that'll be an interesting, and I'm going to ask you in the same breath, you talked on that one slide about some of the structural things like MOUs and SOPs and so on, you know, that help with partnerships. Bluntly, is what's more important in this when we're starting, style or substance?
I think style is always more important. People talk about the 10-second handshake, where basically you decide or don't decide whether you want to work with someone, hire someone, like, take on someone as an employee within the space of anywhere from 2 to 10 seconds. So it's a gut feeling. It's about how people behave, how people act, and people underestimate sometimes the power of style. You can also get burnt by it. Some people are very persuasive, and you discover later on it was all style and there was no substance. Nevertheless, it is very important if you're going into a partnership relationship, you don't go in as the big boss. You don't go in as the big organization who's here to tell us poor folks how to develop our program. And I think when you have people who have trained together, grown up together, like, for example, the experience, say, with Raul and Gaston, and in Latin America, etc., like, that's less of an issue because they, to some extent, know each other from earlier times. And sorry, Alan, the second thing you wanted clarified is support staff. So for support staff, I added that only because like people focus on physicians and nurses, but sometimes you have people like radiation therapists or even physical therapists, occupation therapists, people who help patients and yet get left out of this mix because in the hospital hierarchy, physicians and nurses are seen as the caregivers and very often the leaders of any program. And yet, all of these, the radiation tech who's so good at making kids relax and is able to get a CT scan or an MRI without having to put them through sedation. I mean, all these people have value. And so, yes, it's a little demeaning to say support staff, but I didn't know how else to encompass them. Caregivers sounds even worse to some extent, but that's the new sort of mantra is like, the health caregivers. But, all
So
the
Diane, I think,
our kids' lives easier, right?
oh, forgive me, Vic, sorry. I think Diane, so Vic means everyone. That's very inclusive. There's some great things coming up in the chat that I'm going to reflect back to Richard for one, the question from Poonam, but she already, thank you Poonam, already, Poonam Bagai that is, already posed this question of adolescence. And so here's a question for you, Lila. Instead of this problem, because we don't have WHO, the band that is raising extraordinary amounts of money for adolescent cancer, as they've done so wonderfully in the United Kingdom. And in low and middle income country settings, the adolescents have often, we know they fall in the cracks, but can't we flip it? Can't adolescence be the start of a relationship, Lila? You're on mute. No, still.
Okay, it's okay. I fully agree because there is already a bridge between the pediatric oncology and adult oncology. We just have to go one through the other, because this bridge, it's adolescents and young adults. So there is clearly already a field for collaboration and communication with the adults.
Great, thank you. And Rashmi, you kind of touched on a similar thing in the chat in terms of research capacity. So there's a question there from Poonam again. Probably Richard, you're going to have to take that one, which is, can you pick three? Are there three? I mean, she said three. You don't have to give us three research collaborations that spring to mind that would make sense. You spoke a lot about systems earlier.
Yeah, I mean, my first one, I still stick by the Credo model. I still think that's a phenomenal idea of bringing oncologists, pediatric, hem-onc, all of those individuals together in research methods and having them together, trained together, and not separated out into their own training silos. Because I just think that's built some amazing bridges and some really deep relationships. The second thing, as you rightly said, is implementation science. It really saddens me to see a lot of early detection programs being funded in the IS space and the HSR space, which is just adults only. And they haven't included childhood cancers in that. And I think that's a really, really rich area where, you know, programmatic research funding can focus on both adults and children, the pathways to early diagnosis, and then quasi-experimental or step wedge designs for the implementation side, and actually include both, because you very rarely see that. And thirdly, you know, I want to just allude, you know, there's been some amazing progress of the ITCC and others in the drug development field. You know, there's clearly a need, you know, because I'm always accused of being a Luddite, and, you know, it's not true. My PhD was in biochemistry and cell signaling. There's a real need for new therapeutic inventions. And I really do think there's some very specific areas there that could be really fostered. I think there's been a lot of good words said. I'm not sure when I look at the research portfolios and ICRP and the outputs that really teams have been brought together in that manner to look at new therapeutic options in the way that I think was envisaged many years ago by the pediatric oncology community. So those are my three areas.
Yeah, I think that makes a lot of sense. I want to ask Richard, and Vic and Lila. The question from Rashmi is about public policy as an area for integration, and clearly GICC and guys, that's a whole webinar in itself, but it's important, and I'm sure the pediatricians in this webinar are very granular with that, but in the Indian context and in GFAOP and Morocco in particular, to what degree is public policy driven change in oncology practice, and to what degree has it been driven by medics and health systems, and how do we change that? Maybe.
Yeah, GICC is very important for low and middle income setting, because most of them were doing pediatric oncology and having pediatric oncology activity without clear guidelines. And when there was some guidelines, there was guidelines brought by foreign partners and not really adapted to the context. So with the GICC, each country can have a clear vision, and this will be similar to the overall lines in other countries. So we can do similar work, but each country will adapt to its own context, and we have a similar objective. So this is really useful for low middle income setting.
So I agree with Lel on that. There is no one size fits all. I think whichever country, whichever context you're in, you're probably going to find different solutions. I asked about India and what role the government played in actually driving this. So, like most things in India, the government was kind of like a passive player in that at least they didn't hinder their effort. They contributed in the sense that they are funding, like, significant portions of the Indian health system. That's something we tend to forget about, directly and indirectly. A lot of the funding for healthcare is coming through the Indian government and through the taxpayer. But at the end of the day, how this healthcare is delivered and some of these initiatives very much take place at an individual level with people talking together. And I think the same thing is mirrored to some extent when you look at even larger organizations. So when you're looking at the WHO, IAEA, you find people within there kind of like, for it's a plus and a minus. People talk about cliques forming. At the same time, it's these cliques which form and then are able to get something done in that one area. So, rightly or wrongly, it's very hard to address a huge issue, a global issue, get this kind of pediatric adult partnership underway, by with the government as the driving force, or governments as driving force, or even global health bodies as driving force. This has to come from individuals at the end of the day. And then it kind of, works its way upwards and downwards through the system. But I'll stop at that point.
Oh, thank you, Vic. Actually, it's interesting. In parallel, Guillermo wrote a long and very nice nuanced comment in the chat about I point you in that direction, cautioning me in particular for my public policy comment, that sometimes public policy undoes you instead of does you, and that clearly we need to, as you say, Vic, work from the bottom up as well as the top down. So thank you, Guillermo. There's a challenge to us that I was, when I say us, I mean those of us who are members of SARP, to consider how we can be more effective or work differently in the space. And I was going to put that's Neil Ranasinghe put that down just now. I was going to put it to Richard, but I'm in deference to the chair of Childhood Cancer International, which is the Parents and Survivors Organization. I'm going to ask him the same question. Coming out of adult oncology, where the family model is a little bit different to the family model in pediatrics, what advice would you have for Jean about how CCI can impact in this paradigm? I realize it's a curveball.
No, but I think the CCI, again, it comes to where is childhood cancer, where is it so much further than adult, and particularly in the families, the engagement with the families and the advocacy in that way. Adult oncology is quite far behind in that. I mean, it's starting to grow in LMICs, but you've got very, very nice models of family engagement, family involvement in research, and guiding that. And it's something that is a cross-disciplinary, where adults haven't been good and where we haven't learned. Twinning, your engagement with families and the public. There's lots of things from an adult community we don't do very well at all that the pediatric community do extremely well. And I guess something else to say, layering it on that, is the narrative, as I talked about this earlier, is the compression of countries under their economies. A lot of the narrative at the highest level now is about big picture stuff. So maternal and child health, for example. And I guess in my back of my head, we've been thinking in the adult world is, how on earth do you include oncology into that narrative? Because really, when we're talking about maternal and child health, people will often think purely about reproductive health. But the reality is, let's say oncological work in surgeons, in pelvic surgeons, they have to cope with total abdominal hysterectomies for cancer of the cervix, as well as PPH, uterine ligation. Everyone has to do everything. And I guess one of the things for me is exactly about this. I mean, the personal determination is one issue, but from a policy perspective is, how do we bring both childhood and adult oncologies into this child and maternal narrative? Because that is where a lot of the health system strengthening money is going to end up going and being focused. And I think it's a big challenge for both groups, actually, not just one or the other.
It's a nice opportunity perhaps for us to lead if we can just find the niche in that respect. I want to pick out and forgive me, there's quite a lot of things on the chat. So just Shweta has asked twice now, I think, to emphasize the point. How do we advocate effectively in low and middle income countries where other childhood illnesses take priority? Now, in a way, that's the most simple and straightforward question, and in part, I want to repose the question to Lila and Vic and say, isn't this part of Richard's model that, and so this is a inclusivist concept, that becoming more involved in it, our willingness to be more visible in broader pediatrics as oncologists and hematologists may have positive unintended consequences. Maybe I'm being too subtle, but that's why we'd be talking about involvement in things like universal health coverage. Do you think that's a proper priority on the ground in South Asia and in sub-Saharan Africa?
Not sure, but we got to train the people on the ground and the NGOs that are supporting those teams to teach them how to seize such opportunities, such the Childhood Cancer International Day and World Cancer Day, to make their own advocacy campaign, but being part of a global initiative. And this will give them much more power for the government to support them. And the GICC is a very important opportunity for us as pediatric oncologists, but still there is a lot of teams in low middle income cities that are not aware that there is a WHO initiative for childhood cancer, and even if they are informed, they don't know how they can use this to improve the situation on the ground. So this is the responsibility of SIOP, of CCI, and to help those teams and teach them how they can do to improve the situation, but always being part of a global initiative. One person alone cannot do a lot in a low middle income city.
I think Lala summarized it up admirably. Again, it's going to vary. If your infant mortality rate is 150 or higher, then maybe oncology, pediatric oncology should not be priority for that particular country. So I think trying to roll it, I think this is true of all programs in general everywhere. So you have to adapt them, you have to look at the local environment, look at the situation, and then decide. India today is very different to India 2 decades ago in terms of mortality rate, etc., which is why childhood cancer has now become much more visible. And the same thing is happening across many parts of many other low middle income countries. That this is now becoming a visible problem, which is impacting parents, impacting families, and causing distress. Whereas, 2, 3, 4 decades ago, this may not have been a priority for many families in that particular country, that particular sort of region. So I think it's important for SIOP, for other agencies, anybody who's advising on such matters, to give a reality check also to large agencies who are plunging into these programs to say, okay, like, this may not be, in the end, we want the most good for the most number. I think that's all of us want that, whether it's in oncology, whether it's in infectious disease, doesn't matter what the area is. As physicians, we want the best, greatest good for the greatest number, which is easier said than done. It's like, this is always a challenge. Like, Richard will probably step in and give some really good examples about that, but it sounds like a great slogan. It's really hard to put into practice in real life because everybody feels their particular area is crucial. Like, there's a little bit of emotion, there's a little bit of sort of, reality, like, these things go together. That's the nature of doctors. I'll stop.
Thank you, Vic. That's a really nice note to almost end this webinar with a bit of, can I call it positive realism? Can we turn that phrase?
One more slogan.
So there's one last question that I'm picking out before we close off. As a couple of people pointed out the other day, you get 1 hour, and as our participant numbers start to dip, we know that it's pumpkin time. But there was an important, I think, observation and question from Mithra Gilbafian from Iran, who she and I follow each other on Strava. Hi, Mithra. She's asking about national societies. And I must say, for myself, in South Africa, we've seen a real nice coherence or congruence coming out of an almost accidental process where we started to have meetings together nationally, the radiation oncologists and the pediatric oncologists and so on. And that's another potential mechanism. I just wanted to ask Richard, from a UK paradigm, and given your wide travel, how have you seen that as a really useful mechanism? Societies, professional societies, adult and peds?
Yes, where it happens. I don't think it happens enough. I'm always slightly concerned. I mean, I was talking to, a name that people will be familiar, Julie Gray the other day, is medical director now of ASCO, riling at the fact that everything's separated out. There's no integrated sessions where childhood and adults are brought together. And I think, this is something that perhaps, the society ought to spend a little bit more time and effort thinking about, whether it's ESTROs, the ESMOs, the ASCOs, because I think that would make a really big difference, even to have dialogue panels like this amongst adult and pediatric oncologists would make a really big difference to changing some of the discourse. But it's just, that's it. It happens infrequently at the moment.
Okay, I'm gonna close out from the chair. But before I make a last remark, I don't know if Richard, Lila, or Vic, if any of you've just got any last comments that you'd like to make.
What I would like to say to pediatric oncologists from low middle income setting, that their future is through their hands. So they will need to take the control of their future and the future of the childhood, the children they are taking care of. So this was my message. Thank you. Thank you.
Vic?
Sorry, yes, thank you. Sorry, the lights went out here, so I lost Wi-Fi briefly. I lost the last 10 seconds of whatever you're saying. But yes, it's my pleasure this evening, and hopefully we can take this conversation forward and in different forums. And I look forward to everybody pondering over what they heard this evening and working together more closely. That's the key.
And last word, Richard?
I defer back to Vic and Layla. 100% agree to what they say. Thank you.
Fantastic. Thank you very much, folks. And I hope above all else that we've managed to lay out for you this evening, rather than a list of problems, a whole lot of opportunity. Once again, good morning, good afternoon. and good night, and thank you for your attendance.